right? So now if you bind someone, you're just putting that back together, right? That sounds like it's going to put things back anatomically so that you can actually help this person's injury. Now, if you take the same pelvis, you have a vertical shear, right? Someone fell off a building and they landed on one leg before the other. It's going to cause a vertical injury, right? So now your hemipelvises are offset, and now if you bind them, you're going to do this, right? So this is why this is why vertical shear injuries are not always amenable to being bound, right? But now, like Ryan was saying, if you pull back on them and then you bind them, yeah, sure, but that means that you got to pull them down first, right? And if you're doing that, then that's awesome. So now, what's the other one? The other one is lateral compression, right? So you're in a motorcycle, you're in a motor vehicle accident, you got hit, you got T-boned, and so now your hemipelvis is now in like this, right? That's a lateral compression fracture. So now if you bind this, you will only push this in even more, right? And again, along this whole back side of the pelvis is your venous plexus, right? That stupid pelvis we have to learn about once upon a time in anatomy. So it's a very complex plexus of veins that have very few valves in them. So when they are disrupted, they bleed like stink. And this is like when people talk about taking people to the OR for packing, that's what they're packing. They're packing that back area. They also pack the front too, but you pack that back because you want to stop all that bleeding, essentially. So that's why open book really is the only one that is amenable to this. So if you have a patient who comes in and you're wondering, which ones can I bind, put your hands together and sort of think about it. It's logical in that sense.
So with the vertical shear, I assume that there are some that might be very minimally displaced, in which case when you press minimally on them, there will be some movement. And how can you really be sure?
In a lot of these, there will be laxity. Because remember, like we talked about, how are you doing your pelvic exam, right? Some people have been taught perhaps that you kind of grab onto the ACES and you push down onto the bed, or some people will tell you to rock on it. The problem with a lot of those techniques is, again, it will disrupt that plexus when you do any of those things. So you grab the crest and you squeeze medially, and if it moves and the patient says, ouch, that hurt, then you have a good likelihood of having a pelvic injury. You're right, it's really hard sometimes to tell just by looking. The vertical shear might be obvious because you'll see that the ACES is not equal. And for lateral compression even, sometimes you'll see that one is further in versus the other. And those are in major fractures. Sometimes it's a lot more subtle, in which case you can put the sheets on, and if you have the ability to wait 3 minutes to get the x-ray, then it'll give you the information before you bind them. Unless it's really obvious, if you can actually see like the open book, which does happen sometimes as well.
The legs will be different lengths too, not just, it's easier to see looking at the heel leg.
Yeah, exactly. So who wants to practice how to bind, and who wants to practice retrograde urethrogram? All right, so we have all this stuff. Let's bring it up to the table. I want you guys to come up. You guys can come up. For urethral injury, CT scan is not very good because oftentimes the fluid is held within the bladder, right? Like your sphincter is probably intact, so you're not going to urinate the fluid that's from the CAT scan itself. So it's not good for that. You can do CT cystograms, right? Which happens a lot of the time sort of secondary to a delayed phase, essentially, anyway. But for urethral injuries, not as much. Now, a lot of trauma guys will say, like, I don't really ever do rugs, I just shove the Foley in, and then we'll figure it out later, sort of a thing. That is acceptable as well, but in the unfortunate case where you have like a 90% urethral injury and you put the Foley in and you disrupt it completely, then it really sucks for your patient. There might be a few choice words in between that sentence. So Leon, Dr. Boudakis was actually going to come and be a part of this as well, and he and I were going to have a little bit of a debate about shoving the Foley in versus doing the rug. And the idea is, again, in most traumas, it's not a complete injury, so you're not, and even it's not even a 90% injury, so you're not as concerned about causing a complete injury, but in that few chances that that might actually. There have been cases where it is just isolated, penile trauma or something of that sort. In which case, this is just faster and easier and less radiation and, less additional trauma to the patient. Like putting a whole Foley in also kind of sucks.
So how much should we be advocating for that trauma patient if surgery wants to put in fully? How much are we concerned for urethral injury? How strong?
Yeah, if you're concerned for urethral injury, like you have all the signs and symptoms, I don't think anyone in the room would fault you for wanting to do a rub first.
It doesn't take that long.
Yeah,
It's not.
it's the same time as it takes to do the pelvic plate. You can probably do them at the same time. All right, come on up, guys.